chat, use Q&A, or raise your little virtual hand if you have any questions today. We love making this interactive. And now, without further ado, let me welcome our two panelists to the stage, Dr. Canterbury and Tracy Faulkner. Number one, I am thrilled to have both of you on and talk about what I am sure is not a very well-known practice of drug deprescribing, and hopefully we can get the word out, because I think this is super important. But before we dive into the discussion, let's get to know the two of you a little bit better. Dr. Canterbury, if you want to go first, tell us a little bit about your background and what led you to pioneering this unique practice.
Yeah, absolutely. And thank you again for having us on. My name is Dr. DeLon Canterbury. I'm a board certified geriatric pharmacist, and I hail from the background of retail pharmacy. So I used to be a Walgreens pharmacy manager based in the Durham, North Carolina area. And unfortunately, I saw so much overprescribing. And frankly, I was a part of the overprescribing issues. And so I would find our older adults taking tons of medications that had terrible side effects. And no one was really questioning if this was really improving their quality of life. And so apart from just seeing it day after day and then not feeling really the best suited to advocate, because I wasn't familiar at the time with geriatric medicine or senior care. And so seeing that inspired me to get my certification and eventually learn how to advocate a bit differently for our older adults. So because of that, that actually transitioned to my business, GeriatRx, where we focus on providing this consulting concierge service and giving people that clarity and peace of mind about what the medications may be doing.
I love it. And I dropped in the website there for folks to click over and learn more about you. Okay. And now, Tracy Faulkner, you're a pharmacist too. And one of the many things that you do is you've trained under and gone through training from Dr. Canterbury on the deprescribing, correct?
That is correct. Good afternoon. Hello, Steve. Thank you so much for having me. And yes, Dr. Canterbury, we are colleagues. I'm actually a pharmacist as well. Had a different route to pharmacy in the sense that I worked hospital pharmacy, also within the pharmaceutical industry. And something that I've done since I was very young and really didn't realize that that's what I was doing is patient advocacy and caregiving. So may I continue to tell a little bit about the reason how I got to?
Oh, absolutely. And also I wanted to let folks know that Tracy called me, 30 minutes before this discussion, and was at the hospital with one of our clients. And so our fingers are crossed that everything is going to go okay. But I wanted to let folks know if we see Tracy has to leave, it's because she was notified by the client that she needs to be there, which is just speaking to your practice. But yeah, keep on going on your background.
So essentially, I had the awesome experience of growing up in a home with my great grandparents and my grandmother. So I like to say my mother had a nanny before it was really a term when I was born. And my great grandmother was a midwife, and she was also an educator in rural Virginia, born in 1900. My great grandfather was born in the late 1890s. So they were essentially my babysitters, but they always gave me assignments. Go to this person's house, go do this, go do that. My great grandmother passed away when I was in the second grade of a heart attack. I had experienced her actually having insulin-dependent diabetes and using glass syringes, where she used to drop her insulin, sterilize it with hot water, and reuse her syringes. Okay. And she was also a nurse and an active midwife until the early 1970s. And she also had been a teacher, so multitasking, I guess I should say. My great grandfather was a merchant and was in the agricultural industry. The reason I talk about them is they are the reason why I do what I do. My great grandfather actually succumbed to prostate cancer in the late 1980s, and that was prior to all the new treatments, novel medications. He was a statistic. And the reason was during his time, he was in his 80s. The only option you had was the TURP procedure, where they actually remove the prostate. And with him being an African-American man in the South, thinking, oh, they're just going to castrate me. So I don't want to do that. And I don't want to have chemo. If this is going to kill me, I'm going to live with this. So he was diagnosed in the mid 1980s, and he lived for 4 years and unfortunately succumbed to METs, and his prostate cancer metastasized to his liver and into his bones. And also with that, I was very young, and he did not want me to ever see him sick. He's like, no, if I'm going to be ill, if someone has to wait on me, I'd rather die first than to have my family take care of me. So he had the pleasures of actually dying at home in his time. Okay. So that gives you a little bit about how I came to this focus. So in pharmacy school, I had an interest in the pharmaceutical industry and doing education. I worked in the patient assistance programs. So my very first job was with Merck when Mevacor, which is a cholesterol drug that we don't even use anymore, that was the very first drug. And they had a patient assistance program. So you'd have women calling in, well, I think I have issues with my prostate. Like, no, only men have prostate glands. Having issues with my cholesterol. So we were actually able to help individuals to receive funding to support their cost. So just a little bit about.
I love it. And so let's dive into this, the topic of drug deprescribing. And then also I want to make sure that we bring up precision medicine, because I think that's fascinating again. But before we do that, we've got there's somebody had an interesting, I think I want to read this comment because it might be a great way to sort of talk about this unique practice. And what she says is, I'm an RN and this is not a new practice. A different approach is called a drug holiday, which would often see patients get better. Then many drugs were often left out of the restart of the critically necessary meds. And personally, I've heard of that too, but I like the term. I like the term drug deprescribing or a prescription review much better than a drug holiday. I think a drug holiday is what we were doing at Woodstock, or it could be implied by that. But Dr. Canterbury, tell us a little bit about this term and what is entailed in the training that's involved.
Yeah. So this is something that we see quite often in the world of geriatric medicine. However, it's not generally seen across the board in other populations. And so, to be technical, the term deprescribing was coined in 2003 by an Australian researcher who was interested in this field of study. We've had different phrases like med management, medication optimization, drug holidays, whatever you want to phrase it. But we, as pharmacists, this is one of our skill sets in identifying what's potentially harmful, what may or may not be effective. You may have things like, for example, antibiotic stewardship, fancy word for not using the wrong antibiotics. So we've been doing this in training, right? But where I see the future vision of deprescribing is making this something that a caregiver can learn, a community patient can learn or leverage or have conversations around. You see, it doesn't just start with, oh, the doctor says we can stop it now. It actually starts with, are you aware that we could possibly stop this medication? Are you aware that there are other options in probably looking at lifestyle changes, exercise, and diet? Have you actually been on something so long? Have you questioned whether you truly need it or not? You see, it's asking these type of probing questions that I feel can kickstart the deprescribing conversation. So it's not always say a med review and we found it to stop. Frankly, we have an over-medicated population, and it shouldn't just be done in silos in long-term care facilities or hospice. It needs to be an ongoing dialogue that can be led by caregivers, and it could be done for younger kids to older adults.
I love it. And I'll drop this into chat. A few weeks ago, we had a discussion with Dr. Bill Thomas, who's a pioneer in the greenhouse concept. And somebody asked a question, and one of his things was, he goes, the reason that our older adults and that we as a society are overprescribed is because it's really easy. Your doctor has a limited amount of time. And the way they solve the problem is write something on a prescription pad and hand it to the person, when in reality, the harder thing is coming up with the alternative solution, which might be changing your diet, exercising, drinking more water. I mean, the solutions to some of the challenges that we're facing are many, but the easy solution is writing that prescription. And I'm curious, do you feel that that's accurate? That we've made it too easy to write a script to solve our healthcare problems?
It's so accurate. In addition, it's frankly the American way. We want things fast, now, quick. We want to go to the doctor and have an answer, right? We don't want to get the long solution. And so we want immediate results. And so when you have that mentality, it becomes a little bit harder for physicians or prescribers to come up with that type of plan. Not to mention, additionally, we have a health system that doesn't quite incentivize financially or reimburse for these types of preventative measures. So we already have a systemic issue. Then we have a cultural need to have to take something because we want quick answers. And so there are a lot of factors here that lead up to this overprescribing, climate. And it's not just the US. This is all across the world. The World Health Organization ranks inappropriate and harmful medication side effects as being the #3 threat to humanity. So it's way deeper than just, what we may see here. But yeah, there are a number of reasons why this happens. And yeah, it's just way easier.
Okay, so let's dive into, I love disruptive healthcare approaches, and I would classify this as a disruptive approach. It's going against the grain of what's normal and regular. But let's kind of get it down to the patient experience or the client experience. If the two of you can kind of give me sort of a picture of what this looks like. So let's say that I'm concerned about my mom, and I want to make sure that she's taking the right medications and not being overprescribed. And then what does that experience look like, and who do I call, and how do I figure this out?
Precisely. Tracy, I'll let you take away.
Okay. Well, I wanted to add to everything that you both have said. Sometimes deprescribing may not be just stopping a med, it may be changing it. And I'll give you an example of that. Say, for instance, let's just say you call me or you talk to Dr. Canterbury and say, my mom has this issue with incontinence. She really doesn't want to go anyplace because she doesn't want to have to rush to find the bathroom. Well, if we look at her meds, she went to the doctor and she told them about this. So they prescribed another medicine so that she won't have the issue of incontinence. But really, the only thing that really needed to be done was we could adjust her water pill that she's taking if she needs it for her blood pressure, and have her take it in the middle of the day. Like, say, for instance, she wants to go to the social event or the luncheon. Okay, she takes her water pill when she comes back home. Is she taking it once a day as opposed to take it in the morning with all her meds and she's rushing to the bathroom? And it's working, it works, but it's an inconvenience to her social life. And social interactions are very important. So that's just one example. We could say, well, you can adjust it and take it in the afternoons when you're home. You have time to go to the bathroom as many times as you want, and you won't have that social sense of embarrassment. Okay. That's one example. Another example is you have a patient that has high blood pressure and they've been on the same medicine for over 20 years. The dose has never been adjusted and their blood pressures, they're always passing out. Well, we found out that they actually are eating really well. They don't eat a lot of salt. They're watching their potassium, the like, and they're actually what's called normotensive. So they don't really need the water pill unless they have a sense that their feet are swollen or the like, or it's one day that, okay, I went to the barbecue and there's a lot of sodium in the food they're eating and they retain water. So that's another example of how deprescribing can work. And Dr. Canterbury, please add if you'd like. Those are just two simple examples.
No, those are great scenarios.
And
So, yeah, go ahead, Steve.
And like how do I find a pharmacist or a medical practitioner that embraces this or can help us get this diagnosis?
For sure. So maybe a little tricky in this health system. If it's great when you have certain physicians that have this mindset, when you're able to have an open dialogue and discuss what are my options. Some most honestly want what's best for their patient, want to meet those goals. So if you're able to have that convo, generally you can kind of kickstart that deprescribing momentum. Particularly, I'd say geriatricians are the most versed at deprescribing. That's literally their practice, is getting people off of the meds that are causing more harm. But I would also say geriatric pharmacists are quite trained in this. So you're not going to commonly see, a deprescribing advocate or pharmacist at any, old pharmacy per se. So you're going to have more of these businesses come up like mine and Tracy's that are more patient advocate friendly and forward focusing and concierge. So apart from just reaching out to us, there is an entire space of wellness, medicine, health practices, holistic healing, naturopath types of doctors. They're functional wellness experts, and they try to treat the whole body. And in that essence, they're looking to reduce unnecessary meds as well as a part of their just way of thinking. So they're more about the root cause of the issues, where we believe generally that medications are just kind of band-aids, quick fixes that don't solve the entire problem. And not all medicines are bad, of course. It's just the ones that we think are inappropriate or no longer necessary.
Well, and I just dropped into chat a discussion that we had earlier in the year with a woman, Ginger Smith, who was in a nursing home for 2 years. She was diagnosed with dementia, mania, like all of these horrible conditions. She was put on hospice. And I think one of the practices of hospice is to take the patients off everything except for pain medicine. And when they did that, she started to recover. And this discussion is absolutely amazing because she's now living in a condo in California. She's not in a nursing home anymore. She doesn't have a dementia diagnosis, and she's living independently. And during our discussion, we learned that she was on 20 meds in the nursing home. If we are concerned that we feel like our loved ones may not have the right mix of meds, or that there's a concern, what are some of the warning signs? Like, what are some of the things that we should do, or should all of us be doing this like on an annual basis? What are the best practices?
So some of the core tenets we teach as a part of our deprescribing accelerator curriculum is how to ask those type of questions. And so one of the first ones that come up are, is your patient or loved one on more than 5 medications? And so we define being on 5 or more medications as essentially what we call polypharmacy, so the use of multiple chronic meds. And the higher your medication list, there's an association of higher mortality. So one way for you as a caregiver or loved one to ask or advocate is, have you noticed any physical changes once you've started a medication? Or have you seen changes even after you started a medication? What are the changes you've witnessed? Are those medications absolutely vital? And are they absolutely necessary for you to live? Those are the two main questions I want everyone asking about all medications that someone may be on. Apart from looking for side effects, physical changes in the body, we want to look out for any increases in falls. We want to look out for any, over sedation, any changes in memory. Those aren't necessarily normal signs of aging. So we want to make sure there aren't medicines causing that. So honestly, Steve, we hear about people graduating hospice all the time. They come there crazy with meds. They get taken off of a couple, and they're able to leave and go home, which Fran also mentioned. So I love that she pointed that out. So my goal is, why do we have to wait for hospice? Why not ask Tracy or myself to literally do the review when they're in their 50s and 60s before it gets to that point? So how much money are we eventually saving our clients? And honestly, life. You can't put a price on someone's life. And that's the mindset, I believe, that needs to shift when it comes to the aging industry, is we shouldn't have to wait till it's the end of the road. Let's do this holistically and preventatively now, and make this a common narrative. So that's what's missing, to be honest with you. And it doesn't just have to be a pharmacist-led discussion or a nurse. It can literally be a caregiver who's like, you know what, mom is on too many meds. I refuse to make this happen, especially if you're seeing 20 meds and up, 15 and up. It's time to have a very frank conversation about that, and assess what is the lifetime of each medication. How long do we have to do this?
Okay. And then I love this. I'm sharing my screen here. So this is on Dr. Canterbury's website, and this is the Deprescribing Accelerator. And I love this. The Deprescribing Accelerator is an interactive coaching program for geriatric clinicians, pharmacists, nurses, and senior care organizations who are ready to stop harmful medication use in seniors. And so I could see where having some staff members at an assisted living or in a home care environment going through this training could really open people's eyes up to a better life in your assisted living or in your elder care setting. Are you getting folks outside sort of the pharmacy profession going through the accelerator?
Yes.
Great. And then let's see. Okay, we have a question. It says, how about overprescribing? My doctors often start me on a dosage that is too high. So is that something that is that you see out there, is that physicians are doing?
Yeah, absolutely. We see inappropriate doses for gender, for age, for weight. There are a number of variables. And yeah, sometimes depending on your kidney function, liver function, there are a lot of factors that can come into play with that. So yeah, and then that's also a form of deprescribing in a way, is like, how are we optimizing the dose? How are we lowering the dose? And it could be a gradual dose lowering, and you may not stop it, but in a way that is a successful deprescribing way.
Okay, well, this is great. We've introduced this concept, and I love it. But I had a discussion a few years ago on the precision medicine practice, and I imagine this goes hand in hand with deprescribing. Can either or both of you talk about what I thought it to be fascinating? I didn't know that it existed. Talk a little bit about what precision medicine is and how that can play a role in us taking the right medications if we're taking medications.
Oh, gladly, if you'd like. Precision medicine is just how it sounds. It is the treatment or the plan that's best for you. It's personalized just for you. So you may have heard the term right dose at the right time for the right person for the right condition. Okay, that's just putting it in simplistic terms. We always talk about genes. Everybody's heard of ancestry DNA and the like. There's something that we use in pharmacy or is used in precision medicine where we can actually have a swab, use a swab in the cheek and inside your mouth, and that can be tested and we can find out how your body actually will use certain drugs. Some people don't have any issues with any type of drugs that they may have to use currently or in the future. Some people, well, that drug, there's certain enzymes or genes in their body that cause them to require less of the normal dose or what's actually scheduled. And there's some people that as soon as you give them a drug, man, it's just, they just utilize it, or we like to say metabolize very rapidly. So they may require more frequent dosing or a larger amount of the dose. So that's putting it in simplistic terms of what we do. A good example of that is in the case of orthopedics or surgery. Let's just say you're having an elective surgery, having a knee replacement. Your orthopedic surgeon or PA or whomever may order a precision medicine test. And what they want to do is to see, in the event that you may need pain medication, will your body actually utilize it. So there's a test that we can do to say, oh, okay, this person really isn't a drug seeker. Their body uses more than was required. So they're not labeled incorrectly, right? Or this person may not be able to break down a pain med. So no matter what you give them, the end result is their pain is not being relieved. So those things are all very helpful in planning for that person's care when they're having surgery. Or, you always say 7 days before, stop all blood thinners. What if the person has to use a blood thinner after surgery? Well, if their body doesn't break that down, they may either bleed or they develop a clot. So this is just some examples of how precision medicine works.
And when I heard about this, I was just blown away because we all have either experienced it firsthand or have loved ones who are taking a prescription and may end up in the hospital, and you're doing this diagnosis on why are they feeling this way? Well, oh, geez, it was because they took this prescription and their body reacted a different way. And the whole concept that there's, and then, what happens is, so you're in the emergency room, you had this reaction, and then now you're 10 years later, you have a surgery. And if you don't tell that doctor, oh, it was XYZ that made me feel bad that one day, and they took me off and gave me something else, you could be back in the same situation, even worse, because you're coming out of surgery. The idea that we could all have this roadmap to give our medical providers that here is my, what do they call it? What is there a name?
It's called pharmacogenetics or pharmacogenetics, pharmacogenomics, or the terms you hear oftentimes.
I love it. And again, like, how do we find the pharmacists and the people that are qualified to do this evaluation?
Okay, Dr. Canterbury.
Genetic testing is pretty much everywhere. There are labs popping up all over. In fact, people can even directly order a kit themselves straight from a website. You can easily look up genetic pharmacists or precision medicine pharmacists. You'll find this probably more easily on LinkedIn, I'd say, as it's still becoming a newer wave to see pharmacists create their own practice around just doing genetic testing and med reviews. And what we specialize from our program is how do we use genetic testing as a tool to de-prescribe? And that's some of the best parts about our program, as well as educating our clients, our patients on, even retrospectively seeing, hey, that's exactly why I failed that stroke medicine or clopidogrel or blood thinner. So apart from just getting more, I would say, clinicians involved, because there is a lack. I will say not all clinicians are trained in this, so you will have to search for it. But I believe the community needs a better representation of what this means. And that's where I see us as kind of the bridge makers here, is how do we educate people about some of the basics around pharmacogenomic testing? How do we know which labs to choose? How do we know what these results mean? Do I even qualify? And it's honestly applicable to quite a number of health conditions, whether it may be psychiatry, oncology, pain management, cardiovascular disease. Statins, we know, have a role with genetics as well, even certain dementias. We're seeing tons of developments in this field. So it's been around since the early 2000s, but now it's way more accessible. It's much cheaper. And yeah, you can look for a genetic testing pharmacist or precision medicine pharmacist with a quick Google search.
Okay, that's great to know. And when I do the search, it's still, while it's growing, it's still a long way from being something that we can go to CVS and get our genetic pharmacy review. Okay, Kathleen has a question, and I hope that I can do it justice. It's medicines that are necessary to live. What about psychopharmaceuticals? How would you determine if these kinds of medications are necessary to live? And do you understand that question, and can you comment on that?
Yeah, absolutely. A lot of this deprescribing conversation is around what are the risks and what are the benefits of stopping a med or keeping a medicine on. And when it comes to certain psych meds, one, it's going to matter what type of health condition are we treating. Two, we're going to want to discuss, are they well managed? How are they without it? Is it the first medicine and it's worked all their life, or is it the sixth one that they've tried and they've been adding and adding and adding? And I see a lot of that in dementia, where we have 5, 6 different psychopharmaceuticals on board that have no evidence. We're just essentially using off-label FDA indications or off-label use, not FDA indications, to put someone on something to manage a symptom. So you want to, again, look at the holistic picture of the patient. You're going to want to see what happens if we do slowly taper. Is there a same impact? Is there a difference? And someone also cited earlier, but deprescribing.org has a really nice, pretty algorithm that can tell you how to broach this type of approach. And with antipsychotics, they give you some guidelines on how to triage this deprescribing conversation. So yeah, with antidepressants, it's a matter of, hey, is our patient someone who would likely have a suicidal thought, or something, would they be a harm to others, as an example? Or have they just been on buspirone just because they can't sleep, as a bad example? But you want to, again, look at the holistic picture of the patient. What are the patient's goals? And then we want to start consulting with what are the objective risks, what are the objective harms? And if we do try a drug holiday over a couple of weeks, do we see any changes in their progress or worsening? And sometimes there are withdrawal symptoms. So that's something you have to monitor and follow up with. But you could still successfully deprescribe. It's just, again, how low and how fast do we do it?
Great. Okay. Oh, go ahead, Tracy.
Yeah. Also to that, when you're looking at patients, when you're talking about psychopharmaceuticals or any meds, it's also, what is their environment like? Do they eat? Do they smoke? Do they use alcohol? Because that oftentimes can affect the performance of the meds that they're taking for a certain condition. And then there's certain drugs that mimic dementia. So you gotta look at, it's not just the patient and the meds, it's environmental, it's eating. We could get into a whole pharmacy conversation about that, protein binding, just, they're eating a lot of fat. Are they eating, lean meats? They're just so many different things. Certain type of depression medication, you can't have wines and cheeses and the like. So there's so many different aspects to think of when you're considering deprescribing.
And now we're sort of moving into why it's so difficult. Well, these are why it's so easy for a doctor to just write a script versus a lifestyle change that could make a positive impact. Let's see. Someone has a question. What kinds of certification should we be looking for someone to review our meds from a genomic perspective, among others? Is there sort of a certifying body that we should be looking at, or a trade association?
Yes, there are certificate programs that train clinical nurses, pharmacists, and prescribers. I believe it's community certification in pharmacogenomics. They have a couple of programs that are out there. Usually it's about 20 hours of CE, but honestly, not everyone lists it on their credentials. They may phrase it as a precision medicine expert or genetic testing consultant or something like that, as it's still a fairly new concept. But yeah, they have accrediting bodies for this. They have master's programs for this. Tracy, you have any thoughts?
Yeah, there's one of the first inaugural programs of which I became aware of was University of Florida has a program. They actually have a fellowship training program, like you said, a master's program. University of Pittsburgh, University of Colorado, they all have pharmacogenomic certification programs. And there are others too, but those are the ones that I can think of, right now. And sometimes people will have it listed in LinkedIn if they have a certificate, from those places. Another, is it CPIC? No, I'm trying to think of the governing body that kind of has a list of who has certificates.
Yeah, if you can email me, some of the associations and links, I'll add that to the link that has this recording on it, so that folks can check those out. But yeah, unfortunately, fortunately, the good thing is this is a growth area. The challenge is there's not sort of this good housekeeping seal of approval. Oh, go to, XYZ and you can find all the precision medicine practitioners. So I hope that was helpful to the person that asked the question. And then, okay, now let me see if I've got this one right. Elizabeth says, is there any deprescription clinical trial that provides needed nutrition, since the government that disabled the senior also pays disability benefits too meager to pay for needed nutrition? I hope you all understand that question, but I also, something that may dovetail into that is one of the things we hear a lot about is folks that are on limited income and they're faced with the choice of eating or taking their meds. And oftentimes it's splitting pills in half and not taking a full medication to stretch out the prescription so that they can eat. Do you care to comment on any or all of those things?
Yeah, we have, very significant food deserts in this country, and nutrition, I don't know of any trials that specifically look at deprescribing and nutrition interventions, although it goes hand in hand with deprescribing. So there absolutely are synergies when it comes to holistic wellness and when it comes to using some of those more healthy approaches to hopefully manage a blood pressure or chronic disease. So I believe in that. But to the specific question, I don't know of any. But we know for a fact that food is medicine, movement is medicine. It's going to always be the end all be all. So when we can optimize that as best as we can, it can substitute for the need for some medications. But it doesn't mean that everything that's natural or herbal or supplements are always safe. You still want to make sure you're cross-checking those things with your providers or pharmacists.
And Tricia asks, can you discuss the importance of tapering off certain agents when deprescribing and how that works?
Kind of answered that.
Oh, you guys already answered. Okay.
Kind of answered that when you were talking about.
Oh, I apologize. Okay, good. This is great. I'm just looking at all these things. Let's see. Dixie says a recent client had 11 specialists and a list of medications that exceeded 32 medications. Given his comorbidities, I convinced him and the family that hospice would be a better option. He was 97. What are we doing for our elders? Now on his 7th month of hospice care, each day matters. So I guess, Dixie, you're sort of alluding kind of the story that I was sharing is that hospice sort of has a practice of deprescribing. And now here's this gentleman who's managing probably on limited medications and doing well. Thanks for sharing that story.
Yeah.
Let's see.
Unfortunately, so much time wasted of his life.
Elva says, I lost some trust in the FDA when they approved Aduhelm without much evidence of much, if any, improvement. Their own panel of advisors unanimously said, do not approve Aduhelm, yet they approved it. What does that medication do? And what are your thoughts on the way we're approving drugs and things of that nature?
Aduhelm is the med that was approved for Alzheimer's.
Oh, got it.
On an antibody injection. I don't know much about it. I mean, I did read the trials. I will say that, as we know, in the aging community, everyone is concerned about Alzheimer's. So there's a lot of funding. There may be some pressures for a solution, but I don't really know.
Yeah, so the Aduhelm story surprised me too. And yeah, they preliminarily agreed to not approve the drug and then went back, looked at the data, and then said, oh, you know what? Let's do a deeper dive and we're going to approve this subgroup analysis. And they reversed their decision, where I believe 1 or 2 people on the FDA panel board actually resigned right after that decision. So there was a lot of political pushing to get the drug approved. And so I can't really speak to all the players there. And I also can't just discredit the FDA for everything. I mean, I could say I've lost some of my trust too, but I can't really just say, hey, it's all bad. They have to do a job, and honestly, they have limited resources, so they probably can't patrol everything. But to your point, that's the problem with medicine, is we don't have transparency. Like, I'm going off the information that's readily available to the public.
Right.
Pharma is going to have reams of unpublished data that we're just never going to know. And so that's why it's important to have vigilance when it comes to any changes. When anyone starts anything, ensuring your providers are reporting to FDA MedWatch. Even when COVID vaccines came out, we had surveillance to look for any weird adverse events. So, we ended up seeing pericarditis in kids with some of the Johnson & Johnson vaccines for temporarily. So they changed it and got a warning. So I think you should always have a grain of salt and some skepticism to most medications. It doesn't mean to say that there isn't a clinical use or benefit. There likely is, depending on the population. But yeah, those are just my thoughts initially. I mean, that was the first of many. And I think the bigger picture is, what are the newer Alzheimer's drugs going to be doing, like donanemab, lecanemab, some others that are out there on the pipeline. So I think its approval wasn't necessarily meant for it to succeed. It was meant to open up a door for other similar drugs in the same class to have some benefit, but that's still to be seen.
We'll probably be watching a documentary film or a few books on this topic, like a lot of, the behind the scenes things in the future. But thanks for that. And also I dropped in, Dr. Canterbury shared an article that he wrote on this topic about a year ago, of that prescription drug. And you know, and I'm looking at the clock, and we're getting close to the top of the hour. But you know, one of the things that I think is really bold for both of you, but especially Dr. Canterbury, it's here you are. Do you get any flack from your colleagues or the folks in the pharmaceutical industry? Here you are, a pharmacist, and you're training and created this practice of getting people off medications. It seems counterintuitive to the training that you've gone through. Have you received any flack, or is it, hey, it's about time, you know?
Yeah, I mean, as of now, I have not been sniped or killed by anyone in big pharma, so I'm grateful that I'm still alive. But at the end of the day, ultimately, no. To be frank, providers generally agree that it may be between a rock and a hard place to make this type of stuff happen. Most caregivers and community members want this to happen. Big pharma honestly thinks I'm so small, they're not worried about me and their profits. They're doing fine. So I think holistically speaking, we have a systems-wide issue, man, and everyone knows it. We don't use integrative pharmacists like Tracy who goes to the patient's homes, who goes to their clinics, who goes to their appointments, who does the advocating. She has to do it on behalf of a patient, where honestly, we should have a pharmacist before a prescription is written. You see, it should be discussed. And that's the change that I'm hoping to see with this program, is to not just make this all about, hey, it's all up to the physician who wrote it. Like it's really hard for them to do that. And I acknowledge that. We're here to be team members. We're here to be team players. And I believe nurses are frankly some of the best advocates. I believe social workers are some of the best advocates. So imagine a world where we're training them to think like a deprescribing pharmacist like Tracy, and literally use that to advocate in a way that changes outcomes. That is my approach. So it's not to blaspheme, all these pharma groups. It's really to just change the methodology of how we're treating people over 60 and up. And that's what I love. And so to your point, no, I haven't really gotten pushback, amassed a huge following and belief, and we're hopefully going to change the world with it.
I love it. And Dixie has a really great comment here where she's saying, we need to help our aging patients understand that when our primary doctors refer us out to specialists, we need to ask what the benefits and burdens of the specialty work is and the human cost of intervention. Each specialist adds to the list of meds, and those are managed in silos. I think we all need like a quarterback in this area that is looking at all of the things that we're doing, because these specialists are treating one thing without knowledge of what's going on in the other areas. I think that's very insightful, Dixie.
Steve, if I may add, and Dr. DeLon, you do an incredible job. Pleasure to work with you. And Steve, a pleasure to know you and to be working with you as well. What I'd like to say is that over the years, how we view healthcare is changing. Aging is no longer a bad word. It could be, like your company's called positive aging. It's called aging well. People are understanding that a person like me, what I want to do for my clients is you are the center of your healthcare team. In other words, you need to be empowered. I need to support you. I need to educate you so that you are an integral part. Generation, let's just say your individuals that are 80 plus, a lot of them, well, I just do whatever the doctors tell me to do. That's so that, it is a whole different concept. Now, if you ask somebody that's probably 20 now, well, why? And they're going to look up on their phones and look up all the indications and everything, because they're much more educated, or they're inclined to ask why more so. So now we understand that food is medicine. You know, we may have heard our grandparents or great grandparents say, oh, well, I just use a sassafras tree if I have a sore throat or the like. We're now understanding that it's not just the food that we eat, but what did the food eat? In other words, the soil. There's so many environmental things that contribute to a lot of conditions that are, you know, beyond our control. So medicine has a place. There's certain situations where we do need it. However, sometimes it's food, sometimes it's lifestyle. There's so many different things that contribute to us aging well. Okay, so I listened to a TED Talk a few weeks ago. It was actually from a dean of a medical school. And her idea of the new healthcare provider is, first of all, it's an entire team. It's not just the physician, it's the nurses, it's the occupational therapist, the physical therapist, the pharmacist. The entire team is all a part of the person's team. And with your initial visit, okay, we're going to do a swab to see how your body actually uses medicines, just in case you need them. We already know your genetic profile. And this information is protected, by the way. You know, then we can also do a test. Let's just see if you have any nutrients that you're deficient, or do you have an allergy, or there's so many different things that we can find out proactively in the event that you do need specialized care. So I have a hope. I mean, I know this has gone on for years and years and years, but I do think that we're having a revolution in how we view care and how it's given to us. And as long as we empower our caregivers, whomever they are, and the patient themselves to understand that you don't just have to just say, okay, it's why and what's best for me.
I love it.
Okay.
All right. Well, we are almost done with the hour here, and this has been fascinating. And I'm hoping if you all send me a link to that TED Talk, Tracy, and I'll put it on the link. I dropped in, Tracy, your LinkedIn contact. You said that's a good way for folks to get in touch with you. I'll make sure to put Dr. Canterbury's stuff on there. Elva asks, what's the typical cost of having a genetic testing done?
It's out of pocket. It could be between like $125 up to maybe $500 or $700. Now, if you have insurance or Medicare and Medicaid will depend on your state, whether it covers it. Secondly, you're going to have certain prescriptions that would qualify you to get a genetic test. There are certain meds that just don't have any benefit of you doing so. If you want to just pay for it, it's going to be around that price range. You can get your provider to write it if they're a Medicare provider, of course, with certain prescriptions on board, and it should be pretty much covered completely. If you have original Medicare, if you have a Medicare Advantage plan, there's usually a copay.
Okay, great. Then this is fantastic. Thank you all for what you all are doing. I really get a charge out of anything that's disruptive and pioneering in the healthcare space. And I can see that that our audience is really supportive of this as well. And then Darlene, she says, you know, I'm a board certified patient advocate in Florida, and I specialize in working with seniors. Tracy, you're also a patient advocate as well, in addition to being a pharmacist.
Yes, I don't have the board certification. Well, I did actually go to Dr. Harold Freeman's Patient Navigation Institute back in the early, like 2010 or so. And that was because that's the one I knew about and heard about that through a Washingtonian magazine article talking about Elizabeth Russell, I think her now is Schuler, Patient Navigator company, Washington. So there are, you know, different programs. Mine just kind of started out of just because of the passion I have for aging well.
I love it. And
story,
I think
your family.
it works great. And I think this, again, just like deprescribing, patient advocates are a little known profession that so often people leave the hospital and then they discover that, oh, I could have said no to this treatment, or there was an alternative. And I see the patient advocate community and the deep prescribing community to really going hand in hand as pioneers in this area. I love it.
Two things. I see Tricia Cash said that in Maryland, there's a program, it's called MDPCP, that has pharmacists embedded in primary care physician offices, where offices and home visits are available to patients with Medicare. So you can ask your primary care physicians if they have that service. Also, I will note that in Washington, D.C., it's a similar program to New York. There's the Ralph Lauren Center. He started out one in New York. It was for basically patients' preventative care for cancer all the way to survivorship. And there's now one in the Washington, D.C. area of the same name. The one in New York is now a part of Sloan Kettering, the Cancer Institute there. And there's one now that's in partnership with George Washington University. So I'll send you those links too, that they do patient navigation work. But again, it's prevention, screenings, all the way to if you're diagnosed, if you're having treatment, if you need support as far as transportation, if you need a source of food, all types of supportive care, having someone to talk to about this and to navigate through the process, and then survivorship and celebrating that and continuing to be cancer-free. So
Okay.
another example. So Miss Darlene's husband spent 40 days in the hospital, 18 days in ICU due to fragmented care. That is why I became a patient advocate.
Wow. I love the personal stories.
It's usually out of necessity, it's an experience.
I love it.
Perfect.
All right, folks. Well, we'll see you tomorrow for the Who Can Speak for You. But thank you, Dr. Canterbury and Tracy. You're doing great things. And I hope we can shout this from the rooftops and get more people thinking the way that you are doing it.
Thank you. We'll see you again.
Yes.
You bet.
Thanks.
Talk to you soon.